Good afternoon and welcome to Grand Rounds today. Please remember to fill out the attendance records and leave those at the back of the auditorium. And also please remember to fill out the program evaluations and give us any ideas that you might have in regards to future topics or future speakers. We're always on the lookout for ideas. Today I have the pleasure of introducing Dr. James Trahan. Dr. Trahan is a frequent contributor to Grand Rounds. He is a board-certified psychiatrist, and he is currently the medical director of both the adolescent and the adult behavioral health services here at Mary Greeley Medical Center, and he is here today to update us on the topic of who needs detox. And please join me in welcoming Dr. Trahan.
Thank you, Steve. Well, I thank the CME committee for asking me to talk. My pleasure to do that. Well, as you have all probably read in the news, heard on the news, and maybe even seen over the years the trends, the behavioral health unit numbers are shrinking in the state of Iowa. And ever since I've been here, and this is going on my 26th year on staff at Mary Greeley, we typically had done the detox of patients from every substance imaginable. Well, we're getting to the point we need those beds, hence this lecture. We're working on transitioning to having our medical staff on the medical floors do this and assist them with that when necessary. Can everybody hear me in the back? Hear me in the back? Okay, good. All right. So title of it is Who Needs Detox? Well, just so you get an idea of how big a problem this is, I mean, these figures that you see are related to legal costs, medical costs, psychiatric treatment, you name it. Everything that's wreckage related to any of these three substances or three sets of substances you see here. So we're looking about $560 billion a year, quite a big thing. And if you looked at the dollars that are spent at the federal and state level on substance abuse and addiction in 2005, 95.6 cents of every dollar went to dealing with all these problems related to substance abuse, and then 1.9 cents on prevention. Treatment, 1.9 cents on prevention and treatment, 0.4 cents on research, and then 1.4 cents on taxation or regulation, 0.7 cents, surprisingly, on interdiction. I figured the interdiction costs have been a lot higher than that. So if substance abuse and addiction ended up being a budgetary item on the federal level, it'd be sixth behind the Social Security, National Defense, Income Security, Medicare, and other health programs, including the federal share of Medicaid. So it's a huge item in terms of how it affects our economy. So what do we do about cleaning up the wreckage? Well, detox is kind of where it starts. So what kind of patient might need detoxification? Well, obviously somebody who's intoxicated but has tolerance to the substance. So they have to then be at risk for withdrawal if they're tolerant. Now, if they're just acutely intoxicated, it's just a matter of dealing with that intoxicated state. They're not going to need detoxification as we think of. Obviously, if a patient's intoxicated, possibly tolerant, possibly at risk for withdrawal, they're going to be another candidate. So we don't really know what their tolerance level is. They tell you they're drinking heavily. Maybe they are, maybe they aren't. Maybe they're minimizing. So that's another one we have to kind of consider watching. And if they're already in withdrawal, well, that's a moot point. You're going to need to detoxify them from whatever they're withdrawing from. If they're not actually in withdrawal and you're not really sure whether they're going to withdraw, but you think they could be tolerant, if they've got some sort of medical condition, ischemic heart disease, a seizure disorder, things like that could really become unstable in the process of them withdrawing from a substance, yeah, they're going to need detoxification. Well, not every substance that people abuse is a problem. The biggies are alcohol, kind of listed top to bottom. Alcohol, benzodiazepines, other sedative hypnotics, barbiturates, which we rarely see, opiates, pretty commonly, amphetamines, and stimulants. And then miscellaneous drugs we'll come to. So key concepts I wanted to go over with you first, just to kind of set the stage for this, is the concepts of tolerance, dependence, withdrawal, and intoxication. Tolerance is a need to increase the amount of a substance that one is taking to achieve the same effect, basically, or maintain some level of intoxication. Like one patient I remember, he set a record for a blood alcohol level. He was like over 700 milligrams per cent. 80 is the legal limit. 350 will kill a lot of people. but he was at over 700 milligrams percent. Well, he was obviously able to tolerate quite a bit. He didn't show any signs of intoxication, but he was sure maintaining a high level of an intoxicant to achieve that effect. With tolerance, there's often a markedly diminished effect with continued use. That's very true with opiates. You'll see people's tolerance for the drug go up and up and up. It's not necessarily, though, an indication of psychopathology just because somebody is tolerant to a substance, okay? Well, if you think of tolerance to a beta blocker, for instance, you wouldn't rip away a high dose of a beta blocker because the person's become tolerant to that in terms of beta blockade in their system, and they would have they would have rebound tachycardia, things like that. So you can have tolerance to something physiologically, but it doesn't necessarily mean that it's a psychopathological condition. Dependence, on the other hand, this is a maladaptive pattern of substance use. And these people usually have tolerance to a substance. They're probably going to withdraw from the substance because they're tolerant to it. And they usually they are taking the substance in larger amounts than they ever were supposed to, if they're supposed to take them at all, and over longer periods of time as intended. Case in point, patient breaks their leg, they've got a prior opiate dependency problem, they're now on some pain medications, well, they keep calling the doctor's office wanting more and more. Well, not only call that doctor's office, but maybe they call the next doctor and the next doctor, or they steal their neighbor's opiates, that type of thing. With dependence, the person usually has some degree of craving and desire to continue using the drug. They often make unsuccessful attempts to cut down or control their use of that substance. And they end up spending an inordinate amount of time using the substance, recovering from the substance. So it's really beginning to have an impact on their life in general. They'll sometimes give up their jobs, their family situations, you name it, just to be able to have access and use their substance. And they know what they're doing. I mean, they're doing it despite the knowledge that this is a problem for them. Withdrawal, well, there's a characteristic withdrawal syndrome typically for most substances of abuse. Marijuana, an exception to that rule. It doesn't produce a degree of tolerance with a distinct withdrawal syndrome. But with most substances, there's a characteristic set of symptoms the person is going to experience when they start going into a withdrawal state. With withdrawal, the person is going to try and stop that from happening. If they have opiate withdrawal, boy, they're going to be jonesing for a fix. They're going to want opiates within a certain period of time of their last dose, or they're going to have symptoms. The degree of risk in terms of withdrawing somebody from a substance depends on the substance itself. Alcohol, pretty dangerous. Benzodiazepines, pretty dangerous. Barbiturates, same thing. Intoxication, well, it kind of speaks for itself. The states of intoxication with patients are going to set you up for potentially the most dangerous situations you might face in dealing with somebody who has a substance dependency problem. Sometimes they're disinhibited. Sometimes they're out of control. I already said that. So how do you manage an acutely intoxicated patient? Well, if they're medically stable, but say they have a history of violence, out-of-control behavior, you might want to not just put them on a medical floor. You might want to put them in a more controlled setting, the ICU, or if we have to, up on the behavioral health unit, that type of thing. Medically unstable patients, definitely you're going to want them in a setting where they can be monitored very carefully, maybe even almost on a one-to-one type basis, depending on the substance they're withdrawing from. So an ICU setting, a telemetry setting, maybe with a sitter. And the thing I'll say about patients who need to be put in restraints when they're intoxicated, until that substance is out of their system and you know it's not affecting them anymore, if they've ended up in restraints, you really want to wait until you know that they have gotten their faculties back, their judgmental capacity, their impulse control has been restored to normal. Otherwise, you'll be starting this all over again. Maybe they're quiet for 10 or 15 minutes. Alcoholics particularly, if they come in highly intoxicated and then they kind of pass out, well, if they wake up still intoxicated and you've let them out of restraints, you're going to start all over again with that same degree of agitation, potentially violent type of behavior. And some people are really out of control with alcohol intoxication. They'll do things they wouldn't normally do under the circumstances, obviously. Well, that risk period when they're intoxicated depends on the substance and how rapidly they're clearing that substance from their body. Alcohol, well, 12 to 15 milligrams percent per hour is about as fast as anybody's going to metabolize alcohol when you're at linear kinetics on this drug. You saturate the liver's ability to metabolize the drug, and it's going to be a long time if they're at a blood alcohol level of 300 milligrams percent before they get down below a level that could disinhibit them, say well below 100 milligrams percent. So it's kind of a reiteration of the same thing. If you release them from restraints, probably ought to keep them on one-to-ones at that point if they've had to be in restraints, because you really don't know for sure until they have completely sobered up and they're not having any withdrawal symptoms or having been given medication for detox that could disinhibit them now. Well, sometimes I advise the hospitalist if they have someone who's intoxicated like on alcohol and they're wanting to just tear the place up, they're not withdrawing, they're just belligerent and drunk. Well, if that person's not at risk, they can go to jail. That's public intoxication at its worst when somebody's behaving in that manner. Luckily, we don't have to exercise that option very often. Polydrug abuse. Well, you've got to prioritize which substances are likely going to give you the most trouble in terms of their withdrawal state. Say somebody's on alcohol and amphetamines. Well, alcohol clearly the priority drug there in terms of its risk for a withdrawal syndrome. You have to deal with that. Now, the amphetamine intoxication, if they're intoxicated at the same time they're on alcohol, that poses a other set of problems in terms of withdrawal. It might raise their risk for a seizure, for some type of cardiovascular event, elevations in their blood pressure that are difficult to control. But alcohol is still going to be the primary drug you want to look at in terms of their withdrawal risk and how to treat it. So alcohol and sedative hypnotics, meaning benzodiazepines, barbiturates, drugs like that, they've got the most severe withdrawal symptoms associated with them. Opioid detox, that's probably your next drug of abuse that someone's tolerant to that might need to be prioritized. So if they're not alcohol dependent and they're on an opiate, okay, that's the priority then in terms of what you're going to detox. You're not going to worry about amphetamine detox. They're on opiates and amphetamines, it's opiates next, because they'll have a distinct withdrawal syndrome, usually within 24 or 36 hours of stopping that drug, and they're going to be miserable. Some substances aren't going to require treatment. Marijuana, hallucinogens, they're not going to have a withdrawal syndrome associated with those types of things. Now, not that marijuana can't trigger psychosis in people, because now that's a psychiatric problem you've got to deal with. It's not a withdrawal state or an intoxication state that's necessarily going to be the problem. It's going to be what's happening in their brain in terms of their psychosis that you've got to deal with. Hallucinogens, no withdrawal states associated with it. Inhalants, same thing there. Alcoholics especially come in if they're really chronic and they neglect their nutritional status and alcohol becomes their calories. They can have some pretty bad problems with absorption of nutrients. And protecting them from that, especially with certain vitamin deficiencies that we'll talk about in a bit, is going to be important. People who use a lot of amphetamines, boy, they neglect their intake. They come in very thin, sometimes emaciated. They'll need nutritional replacement at some point, but usually that corrects itself. They come in, and once they're done with their amphetamine withdrawal, they're ready to eat like a horse because they've deprived themselves of nutrients so long. In cases of severe alcohol nutritional problems, you may need to have the dietary staff assist you, dietitian come in, make some recommendations on replacement. A lot of times the key things that we need to replace right away are done in the emergency room, the old banana bag routine that has a whole mixture of things that people are going to need, glucose and thiamine and things like that. Often you deal with that acute thing, and then it's just a matter of how to replete the person after that without a problem. This shows the effects of 1, 2, 3, 4 drinks in a very short period of time on your blood alcohol level. 4 drinks, you're going to get yourself over the legal limit pretty quickly within 2 hours of that. This next slide shows this even better. This shows the effects of 10 total drinks at a certain rate. The blue-green that you can see down here is at 1 drink per hour, 10 drinks though over the period of that time frame. The pink is 2 drinks per hour, and then the purple is 5 drinks per hour. At 5 drinks per hour in that first 2 hours, boy, you drink and then your blood alcohol levels continues to climb, and then it takes a long, long time for it to get down. If you drink 1 drink per hour, your blood alcohol level stays down. Pretty amazing. You've kept your liver at that 0 order kinetic level by drinking 1 drink per hour. Now, I don't advise drinking 10 drinks, obviously, over a 10-hour time frame, but the rule or the take-home on this is if you're going to have anything to drink, you don't drink more than 1 drink per hour, typically, men and women even. Alcohol withdrawal. Well, 24 to 96 hours is a potential time frame in which they can withdraw. Typically, we see them starting within 24 hours, certainly by 48 hours. And if by 48 hours you're not seeing much, they probably aren't going to have significant withdrawal symptoms of when they last stopped drinking, I should say. The biggest thing you get worried about is the risk of seizures, then developing DTs, things like that. You're typically going to see their heart rate go up. Blood pressure may or may not go up until they get further into the withdrawal states. You may see some other sympathetic autonomic activity. Maybe they'll have loose stools. They may be tremulous. Some of that tremulousness, though, can be due to cerebellar injury from the alcohol. And it's easy to get fooled when you're trying to detox somebody and go, oh, they're tremulous. Watch the heart rate. Watch the heart rate. Don't look at the tremors. Those aren't going to tell you a whole lot. Look at their vital signs. And there's a caveat there I'll come back to. So there is a risk of DTs with alcohol withdrawal, obviously. That's the feared complication of alcohol withdrawal, and it's a dangerous state. I mean, untreated, about 40% of those people may die in a non-medical setting. If they go into DTs and they receive no supportive care, 40% will die from it, from seizures, autonomic system problems, things like that. But luckily with treatment, most people pull through it. Everybody thinks of alcohol withdrawal as DTs. It's not. There's alcohol withdrawal, mild, moderate, severe, and then you have DTs. DTs is a delirium state, plain and simple. Now, the guy I told you about with the blood alcohol level over 700 milligrams percent, by the time he got down to 450 milligrams percent, he was well into withdrawal. He was shaking, he was sweating, the autonomic signs, and he needed Librium even though his blood alcohol level was 450 milligrams percent. So it depends on where they live with their blood alcohol level. What are they tolerant to as to when they're likely to start going into withdrawal? So don't be afraid to give someone who's perfectly alert is now showing signs of autonomic instability occurring from alcohol withdrawal to give them Librium, even if their blood alcohol level is sky high. Worst case scenario, they're going to get a little sedated, but probably not if their blood alcohol levels are that high and they're still alert and they're showing signs of withdrawal. So your trends and your vital signs are going to be the key thing in determining what to do with alcohol withdrawal. We have a Librium Detox Protocol that we have put together over the years at Mary Greeley. Works beautifully in most cases. All bets are off when they go into DTs. Despite your best efforts at detoxing somebody with Librium, if somebody's going to go into DTs, it's going to happen. We'll talk about some things that we might do to help prevent that, but honestly, it's very difficult to predict who those folks are going to be. But Librium Detox usually works on 95 or more % of the people with alcohol withdrawal. Works very smoothly, you just have to follow that. I think the biggest problem people get into with the Librium Detox Protocol is giving the patient too much Librium. Well, what happens after a certain point? Actually, their heart rate begins to rise. And now you start chasing that, thinking it's alcohol withdrawal, I need to give them more Librium. Well, then they start showing the dysarthria and the disinhibition, and now you've pushed them back into a state of intoxication. It's actually going to last possibly a couple of days, because Librium has a pretty long half-life, and you get that much in their system that you've got them that disinhibited, you've now overshot your mark. So I usually say, if you're going to use the Librium Detox Protocol, they're checking their vitals every hour. watch their heart rate in the beginning. If it's not up, you wait. You don't give them anything. Even if their blood pressure maybe is up a little bit, wait a little bit. Wait till that next 1 hour interval. Heart rate starts going up, okay, fine. Time to give them a little Librium, all right? Watch that. It's okay to watch the blood pressure too, because the protocol says 150 over 90 on their blood pressure or over 100 on their heart rate, right? But sometimes their heart rate's like 60, and they're not on a beta blocker, suppressing them mounting a little tachycardia from withdrawal. So if they're not on a beta blocker, their heart rate's not going up, their blood pressure's up. I wouldn't worry too much about that. They may very well have essential hypertension, which a lot of chronic alcoholics do have. And you don't want to treat that blood pressure alone in the face of a heart rate that hasn't risen. Alcoholic hallucinosis. This is also not DTs, okay? Alcoholic hallucinosis, I don't see very often, but when you do, it's dramatic. You walk into the room, and the person who's got it, you'll say, "Doc, don't kick the dog there in the room. Step over the dog. He's right there." What dog? They have these form visual hallucinations in a clear sensorium, okay? They're not withdrawing. It's some unusual phenomena related to the effects of alcohol as a toxin on, say, their dopamine and their visual system, their temporal limbic system, things like that. It doesn't have to be treated as we do with detox. It's simply a phenomena related to the effects of the alcohol. It typically goes away pretty quickly once they stop drinking. Of course, they might go into withdrawal, but you don't want to treat alcoholic hallucinosis as a withdrawal syndrome. DTs, on the other hand, yes, they'll have visual hallucinations, tactile hallucinations. They may even be psychotic, but they're going to be disoriented. And they're going to be picking things out of the air. They're going to be agitated, and you're not going to be able to communicate very well with them. They'll wax and wane in terms of their clearness of their sensorium. That's DTs. Alcoholic hallucinosis, won't see it very often, but it's interesting when it happens. We mentioned that. Wernicke's encephalopathy. All right, Wernicke's is generally something we can prevent. And the ED staff here at Mary Greeley are very good about getting that banana bag on board if they see somebody at risk, or we're going to get them a high dose of oral thiamine, IM if necessary, if we really think they're at risk nutritionally, and it'll prevent that. This is related to thiamine deficiency. In people who are chronic alcoholics, they're not eating well, but they're drinking a lot, and they're impairing absorption of thiamine. It can happen with any person who's got a malabsorption syndrome, though. Wernicke's isn't just unique with alcoholism. It can happen with people who have Crohn's, chronic malabsorptive conditions of other type that affect their ability to absorb thiamine. And it has a particular set of symptoms that you never want to miss, because if you miss this and you let it go, your patient's never going to remember anything that you tell them more than a few minutes again, ever. But with this, you can see them a little confused. They may have some truncal ataxia. They're going to have the ophthalmoplegia, where they can't move their eyes certain directions. They're going to seem like they're in a delirium state, and if you don't treat it with some thiamine, they will destroy their hippocampal neurons, and they'll never form short-term memories again. I remember a case that was on a British TV show. It showed the guy who had Wernicke's, and I forget what the cause of his was, if it was alcohol or something else, but he lived in a little room in this institution, and people would walk in, introduce themselves, people he didn't know, and he'd have a wonderful little conversation with them, kind of filling in things, confabulating. They'd walk out of the room, come back in again. He didn't know them from Adam. He'd start the same conversation all over again. The ability to form new memories gone. So we give them thiamine up front. DTs, all right, disorientation, confusion, dramatic autonomic instability. They're going to hallucinate. They're going to be agitated, like I say, picking things out of the air, struggling potentially, and seizures aren't uncommon. And you don't use Dilantin with them. Benzos or phenobarb are the best way to go in DTs if they have seizures. It's obviously an ICU level care situation. You're not going to park this person on telemetry because they can just go south on you so quickly in terms of their condition. At the end of your notes, there'll be a reference on Hoffman. It's a nice little summary of treatment of alcohol withdrawal and its complications. And if you go to that link, it's a really nice one to have if you ever need something like that. Risk factors for DTs. This study came out in 1996, and they had quite a number of patients they looked at who were discharged with a diagnosis of alcohol abuse, and they wanted to understand, why do some of these folks go into DTs? So all those stats in terms of who they are. It says 48% of the patients develop DTs during hospitalization. Well, I'll tell you, that is not our experience here at Mary Greeley. This is a very different crowd of patients they were serving. However, of that 24%, they had a pretty good size sample that allowed them to make some predictions about who in their patient group, and again, not to generalize this to our environment, but in this group, they were more likely African American, they were unemployed, homeless, more likely to have gone more days since their last drink, and to have some sort of acute medical illness associated with it. Maybe it's a pneumonia, UTI, who knows what, infection, sepsis. They often had an elevation of their BUN, probably because they're dehydrated. Respiratory rates were up. They had low albumin levels, so they were really undernourished. And they had low systolic blood pressures, interestingly. If there were none of these factors present, only 9% of their group developed DTs. But if one factor was present, 25%. Two factors, 54%. Again, this may not apply to our patients, but we think about nutritional state, when was the last drink, what are some key indicators of how this person's likely to go through withdrawal, based on their drinking habits. So alcohol withdrawal, talked about Librium. Yeah, use it according to the protocol every hour if needed, right? If they start developing dysarthria, slurred speech, begin to act a little uncoordinated, or they're definitely looking drowsy, or you see some paradoxical increases in heart rate especially, maybe you ought to hold off. Wait till the next vital signs check and see what's the trend. Remember, we're looking at trends here in terms of response to the medication to decide. We don't want to just go by simple numbers. We want to look at the trends here. If your patient can't take oral Librium, or God knows, maybe they have an allergy to it. I've never seen a person allergic to Librium in 26 years, but if they were and you couldn't use oral Librium, which is nicely absorbed, well, you can use IV Ativan. And the new Librium protocol that we're putting out there that'll be available on Epic will have the recommended dosing for that in intervals. Obviously, supportive medical care. You're going to monitor them. If there's a seizure risk, well, seizure precautions. You're going to make sure they're nutritionally repleted and so forth. Hypomagnesemia is your enemy, as is hyponatremia in some of these folks. The reason being, hypomagnesemia, my personal experience, and I can't necessarily find literature to support it, but the cases of patients who went on to have DTs, they had really low magnesium levels. We're talking about 0.8 and well below. Getting them repleted with some IV magnesium will help calm the central nervous system, help offset any risk for withdrawal states. So that hypomagnesemia is an enemy of alcoholics going through withdrawal. And we usually give them oral magnesium supplements on our Librium Detox Protocol. Benzodiazepines, same rules apply basically for detox. And you can use the Librium Detox Protocol for anybody who comes in, say they've got 6 milligrams a day of Xanax or alprazolam that they're taking, and they're a substance abuser, and they shouldn't be on the drug. Well, don't be afraid to say, all right, we're not continuing this. You've got illicit drugs in your urine in addition to your benzos, or maybe they don't even have benzos in their urine, but they're saying they take 6 milligrams of Xanax a day. Fine, use the Librium Detox. Just cut them off, use the Librium Detox Protocol. The shorter half-life benzos, they're going to go into withdrawal faster compared to the longer ones. Alprazolam among the shorter ones, all the way to clonazepam, longer-term ones. In fact, when we stop people on clonazepam, they'd have to be at pretty high doses to actually see much in the way of withdrawal symptoms. It's a lot easier to detox them when they're on that, using that Librium protocol. Opioid intoxication. Well, the ED staff are going to see these folks. The EMS are going to see them. I think there's been a push nationally to try and get Narcan available for addicts that have ready access to it. I think they may have done this in Britain already, you know, where people were dying of all these opiate overdoses, so they're trying to make sure the addicts have Narcan should they or their friend who's using get in trouble. But the ED staff and EMS staff are going to see these folks with small pupils, diminished respiratory effort, which is not a good sign. They can be quite sluggish to unarousable. And at that point, you're going to really need the Narcan. They may be cyanotic from diminished respiratory efforts. That's life-threatening, and that's a problem. That's not a withdrawal state, but you can throw them in a withdrawal state when you use the Narcan, but you're going to have to do it to save their life, obviously, from opioid intoxication. Withdrawal, despite its reputation, the withdrawal from opiates really isn't usually a life-threatening thing. They'd have to have some sort of unstable ischemic heart disease or something else going on that's going to really put them at risk for having a complication should their autonomic nervous system become reactive, or say they have massive diarrhea and they begin to alter their electrolytes. So despite that, this condition really isn't anything to be feared. It's very easy to detox these folks. I already mentioned that. So what are you looking for? Well, lots of different signs and symptoms. They're restless, they get diarrhea, they get cramping, they have goose flesh, they're going to want to curl up in a ball and not want to come out, and you'll see the typical autonomic nervous system signs, runny nose and so forth, all kinds of aches and pains. And they'll really want you to treat their pain. Well, their pain thresholds have changed because they have damaged them temporarily by overusing opiates. We see this also in chronic pain patients. Those that come in and tell me, oh, my skin, it's burning, I've got so much pain all over. That's the patient you want to take off the opiates. Because when they get that kind of increase in analgesic sensations and effects, all right, you know that person really doesn't need to be on the opiates. In fact, the higher you go, the worse the problem gets. Detox them 4 or 5 days later, they'll say to you, why didn't we do this before? I feel so much better than I have in years. Opiate detox. Use the it's now the guanfacine. Maybe it's entitled the Opioid Detox Protocol. It's going to be an EPIC. It's got a lot of comfort medications on there. For a while, we couldn't, well, we still can't get guanabens, which we used to like. It was superior to any of the other two alpha adrenergic type agonist drugs. But 10X doesn't do too badly. You see 10X used a lot of times in kids for ADHD. Well, luckily we do have 10X. It's not become an orphan drug yet, probably because of its popularity with ADHD. So we use that. Clonidine is the second or third best. I don't recommend we use that. We don't even include it on this protocol. We use the 10X. But boy, it works beautifully along with the comfort medications. Just follow the protocol on it, and your patient's going to 4 or 5 days later ease out. Now, they may go into craving. They may say, well, I want to leave. And they leave AMA. Well, they'll probably be back again at some point in the future whenever they run out of their supply. And this time, hopefully, they'll commit to going through the process. It just takes a lot of reassurance and say, I realize you feel horrible right now, and you're going to maybe for a few days, but by day 4 and 5, you're going to be really surprised where you're at in terms of how you're feeling. Just a comment on Suboxone, Subutex, and Methadone. I don't have a license for Suboxone to prescribe that to people for good reason. I'm not a fan of opiate replacement. The reason being the outcomes that they measure these drugs by are diminished use of illicit opiates. We can detox people and they're not going to have craving, and that's a matter of them going into a treatment program where they can develop the coping skills that they don't have to go back to using opiates. So the majority of people who are using these types of drugs, if they are being given these drugs because of opiate dependency, they're going to use, which puts your patient at risk. They could easily overdose on their illicit opiates in addition to these prescription drugs. So I'm not a big fan of them. If you see a patient on one of these and you think they need to be detoxed, same protocol. Stop the drug, use the opiate detox protocol, and things will be fine there. Barbiturates. Don't see this very often. Seen a few cases where Somebody was using, say, Fiorinol. I think it's Fiorinol has a butalbital in it, right? That being a barbiturate-type drug, person's using a lot of that for headaches, and then you suddenly drop them off of that. Barbiturate withdrawal is bad. They can end up going into status epilepticus. So if you think they're having that, detoxing them off of barbiturate is important. Now, in the old days, we had a little book as interns in medical school, Psychiatry for residents, I think it was, something like that. It was before your time, Dr. Stroessel. But anyway, in that book, it had a wonderful barbiturate challenge test, which I searched and searched the internet, and I couldn't find the darn thing for you guys. But if you ever needed, this allowed you to say, all right, we can figure out what the person's tolerance is, and from that point, then we can now taper them off. So otherwise, it's going to be kind of a blind thing. You might get them a little phenobarb. They're sedated. Well, you know, you're probably good for the day. Take a look at how they're doing tomorrow. Give them half that dose. See how they're doing, type of thing. If you ever run into this kind of thing and you want consultation, just call us, because you're not going to see it very often, but it's wicked bad if they go into barbiturate detox. Intoxication, though, is going to look a lot like any sedative hypnotic. Respiratory suppression is an issue with any sedative hypnotic at a high enough dose. Even benzos, but that takes a really high dose of a benzodiazepine to produce respiratory suppression, unless they combine it with alcohol or some other sedative hypnotic. Oh, yeah, it's kind of a deja vu moment. Years back, the group that thought the spaceship, they thought the comet that was coming through was a spaceship coming to take them, right? Heaven's Gate or something like that group. They all put on their little uniforms, climbed in their bunks, took their barbiturates. All 35 of them died. And I think there was maybe but a couple who moved in their sleep. The rest were found with their arms folded or something similar. So barbiturate intoxication and poisoning, it really can take you away quickly. So this is a drug in intoxication you don't want to fool with, and withdrawal you don't want to fool with. I already mentioned that about Fiorinol and so forth. Yeah, this one, like I said, the barbiturate tolerance test, or you'll have to kind of fake it and give them a dose of something that you think might produce sedation. If it doesn't, within an hour or two, give them another dose. Find a sedation point. Well, now you know kind of what their 24-hour tolerance is, and you can start backing down. But you can't drop them more than about 5% per day on barbiturates in terms of the total dose to detox them. It's a very slow process to avoid withdrawal and seizures. Psychostimulant intoxication. Well, you know, they got some slight risk of seizures. We don't see that very often. Usually you're going to see their heart rate up, their blood pressure up. Occasionally in the cocaine days, and certainly people with using IV amphetamines, yeah, there is a risk of stroke. From high blood pressures, it's going to be more of a hemorrhagic stroke rather than an ischemic type stroke. Could see an MI. Cocaine in its day really constricts the vessels supplying the heart muscle, and even a young person can die of an MI with that drug, smoking or IV, because the smoking route of cocaine gives you almost the same levels as it does shooting it intravenously. Cardiac arrest, arrhythmia, not real common. It'd have to be at really high doses, and often in conjunction with them being on some other medications that raise their risk for a cardiac arrhythmia. Hyperthermia can occur with psychostimulant intoxication. It'd have to be a really hot day for that to become an issue. The rave parties that you used to hear about, people take ecstasy and some of these stimulants in combination, they get all worked up, they die of hyperthermia. Psychosis and extreme agitation, that we see pretty frequently. You see chronic amphetamine users come in, you know, the police are after them, there are people in their attic, they've got all kinds of paranoid delusions. It looks just like paranoid schizophrenia in its acute phase. The difference, in a matter of days, that usually disappears, a week or two tops. So psychosis can be pretty significant with psychostimulant intoxication. But that's, again, usually more chronic use, rarely see it with just a few doses. So if they come in psychotic and they tell you, oh, I've only used it once, probably not. Probably not. Psychostimulant withdrawal symptoms, not too much to worry about. They're gonna curl up in a ball, go to sleep. Some of them will want to sleep a lot for days. Most of the time, in a couple of days, they're up and about. You have to worry about them getting a little dehydrated, but usually they wake up, they'll get something to eat because they are usually ravenous by that point, having not eaten for long periods of time because they're chasing their high with their drug. So they usually will eat and drink fluids. If not, and they're on a medical floor, psychiatric floor, have your nurse check on them, offer some fluids, things like that. It's pretty simple. They're not going to have some life-threatening withdrawal condition associated with psychostimulants. They can be irritable, though, usually if you wake them up. So you really need more than a place to sleep it off for that type of thing. DVT, if they're at risk for DVT, women smokers who are on birth control pills who come in withdrawing and they're really inert, staying in bed, okay, maybe you need to consider Lovenox. Miscellaneous drugs. I saw one case years ago, patient had been taking high-dose baclofen for a long time for some muscle spasm problem. Well, somebody didn't realize that. It was the days before medication reconciliation, as good as that is nowadays. But anyway, they got dropped off their baclofen, and like 3 days later, and this was a professor, he was drinking out of the toilet and chasing dogs down the hall that didn't exist. You know, realized what had happened. We called his wife and said, was there anything else he was taking? You know, was he a drinker? No, he's not a drinker, but yeah, he was on this muscle spasm agent for years, the baclofen. So that's a bad one. And unfortunately, short of maybe barbiturates, you really need to use the baclofen to withdraw them. It's really a very specific drug in terms of treating it for withdrawal. You can't use benzos and expect them to get them through that kind of withdrawal fully safely. SSRIs, well, there's a discontinuation syndrome. It's not usually life-threatening unless they're up on a ladder and they get the weird zingy thing from having stopped their SSRI abruptly. Because it's one of those things where if you turn your head and you've forgotten to take your SSRI agent, that one that causes this, you'll feel like you've got vertigo momentarily, and otherwise it's not a life-threatening thing. So if some of my patients come in, they're complaining of this happening, it's like, okay, you don't want to do certain activities until we can get this back under control with the medication that we were tapering you off of. Prozac, I can't remember having seen this with Prozac except maybe in 1 or 2 cases over the years. It's the shorter half-life drugs, paroxetine for some reason, sertraline, venlafaxine. Those are more prone to people having this. Again, not usually life-threatening, but it's one of those weirdy things that maybe you want to know about. Treatment of co-occurring psychiatric conditions in somebody being detoxified. Well, obviously, some of the medications these folks are on can complicate detox, things that may raise their seizure threshold. In the old days, chlorpromazine was a baddie. If somebody with schizophrenia was on chlorpromazine and they were an alcoholic, boy, you really had them at risk for seizures if you continued the chlorpromazine. Well, we don't see that very often, but there are some drugs, lower potency antipsychotics, higher seizure risk, haloperidol, things like that, low seizure risk. So in a case like that where there's a patient who's on a bunch of psychiatric meds and you're not sure what's likely to happen in the process of detox, you contact us, we consult, we advise you, and go from there. Some of the detox meds can mimic psychiatric conditions. Case in point, fellow got too much alprazolam. Well, he's disinhibited, he was labile, he was threatening, he was out of control, kind of like he was manic. Well, got him off that and that cleared, but then his mania did come through because he needed something else to kind of treat the mania. You'd probably have been using the alprazolam for that. But again, benzodiazepines can produce syndromes of disinhibition in high enough doses. They can make a person look like they've got a mood disorder. Then you end up haldolizing them, if that's a word, which isn't necessarily a good thing. So again, if it's a case where you're concerned that there's going to be an interaction, you call us, we'll be glad to advise you. Some psych meds you definitely don't want to discontinue. If they're on an antipsychotic and they've got a well-vetted psychotic disorder, schizoaffective disorder, bipolar disorder, schizophrenia, you're going to want to try and keep them on some antipsychotic medication to keep you from having an emergence of their psychosis during this time when you're trying to treat their substance dependency problem. So someone's got a comorbid psychiatric condition, you do try and treat that condition as much as you can in conjunction with it Now, depression in somebody coming off of amphetamines, unless they had that before they started using the amphetamines, we're not going to jump in with an antidepressant and treating it. I'm talking about people who have psychotic disorders, for instance, where they're going to rapidly have symptoms if they're off their antipsychotics. Somebody's detoxed and they've got serious depression, fine. We'll see that usually within a matter of days of the detox process, it's going to become clear they have a persistent mood state that now you're going to want to do something about, but you don't have to jump on that day one. Untreated, if you're trying to get somebody detox and then into treatment and keep them sober, if they've got some comorbid psychiatric condition, we obviously want to diagnose that and treat it so that it will lower their risk of relapse. The old days of a dual diagnosis program are coming, I'm afraid. It looks like the governor's talking about shutting down the dual diagnosis program at Mount Pleasant. I think that's what I've heard. It was a good program in the state, one of the few that you could actually count on sending somebody to who had a true comorbid psychiatric condition. Whether it was depression, bipolar disorder, whatever, and they could go to this program and they could stay there 6 weeks or whatever it took to get them well, not only from their mental illness, but from their chemical dependency problems. But dual diagnosis programs are getting harder to come by. Ones that are truly going to take a look at what's going on psychiatrically and in terms of substance dependency. Patients coming into detox are in crisis. Maybe it's just because their supply got interrupted, or maybe they've got some psychosocial pressures, or maybe they finally decided, I'm tired of this, I really want to end this cycle. So it's a crisis either way. It's our opportunity to try and do something to direct them. Detox isn't treatment. It's just one stage, one step in a process of recovery for people with chemical dependency. Yeah, you may see a reduction in drug or alcohol use after detox, but if they can't limit their use, they've got a problem. They can't use that drug again. So detox only gets you to a point, and then you have to have other means of continuing from there. We have a chemical dependency social worker on our ward, and I think there's at least one other person. Chrissy's still certified in the hospital to do CD? Yeah. Okay. Yeah. Many times, we as psychiatric staff don't necessarily have to see the patient if they don't have a comorbid condition. Get our chemical dependency person to come and assess, make recommendations, and decide what to do from there. Occasionally, these folks do have to be committed. They really are not making good decisions, and they probably need to be sent to treatment. But otherwise, she's going to see them, make recommendations for some level of care based on a set protocol that has been developed for deciding on the level of treatment a patient needs. And so that person, our CD counselor, can be contacted to aid you unless you specifically need our input. Patients are going to be more likely to go into treatment if they really think they're going to be helped. So that's where we try and set the stage, build that sense of hope, take a look at, all right, what's happened so far, what could change in your life by doing this, what will be your motivator. That's a little bit of the psychotherapy thing, obviously. If they're employed, it's a big factor. Are they beyond just thinking, well, maybe I should? No, I really need to do this. It's ruining my family. It's ruining my health. I really need to go beyond pre-contemplation here and do something about this. If they have supports, they're more likely to be successful. People who are homeless, living in homeless shelters, living on the street, being evicted from their apartments, being divorced, having been disavowed by family, they're not going to do well. They're going to relapse just about as soon as you send them out of the hospital. If they have co-occurring psychiatric conditions, also a big setup for them to relapse. So if you treat the condition, you have a better chance of them being successful in entering a program and maintaining sobriety. And just some general principles. People can have a whole bunch of things that present. We can stay focused on the chemical dependency thing, but many times there's a whole host of things. I have rarely met the patient who has just a chemical dependency problem. They usually have associated trauma histories, personality disorders, all kinds of other stressors and problems, sometimes other primary psychiatric problems, sometimes chronic medical conditions that really are depressing and are affecting them and so forth. So we want to try and look at the whole patient, obviously. The key thing about managing medical conditions, though, they really aren't different from managing any other patient. It's just we have to be mindful of if they're withdrawing or if they're intoxicated on something, how will that impact those conditions that exist alongside that. If there's any doubt as to whether one of the detox protocols that we have, and they're pretty safe protocols, if there's any doubt about whether it could have a negative impact on the patient, you call us. Night or day, we can answer a question. Well, the blood alcohol level is 350. They seem to be withdrawing. Do I dare give them Librium? Absolutely. Or give them some IV Ativan. You're going to have them in a controlled setting. They're going to be all right, especially if they're showing signs of withdrawal. You need to be on top of that and doing something about it. And then this last is that excellent review of alcohol withdrawal syndromes and their treatment. I think there may be a few additional slides for you on your, like these, on your handouts, and these are just for your review. I'm not necessarily going to go over all these things. All right. Well, that concludes my talk. Open to any questions, or Dr. Earps?
Thanks, Dr. Trahan. For the person, we have them alcohol detox, and they're going to head out of the hospital. We try to get them into Safari, especially if they're getting discharged before 4 days. Is it a good or bad idea to give them a week's worth of Librium?
It's an excellent question. Yeah. You should finish their detox in the hospital. You give them a prescription for Librium, Ativan, whatever, so they can detox at home. They're going to go home, they're going to take the whole bottle, and they're going to drink, and they might have a really bad outcome. The thing that I've seen, Gary, in talking with medical staff, they're afraid, well, if we don't give them some Librium consistently, they're going to go into withdrawal. No, that's exactly why this protocol is a PRN, as needed use of Librium or Ativan for alcohol withdrawal patients. Because a lot of them, 24 hours later, they haven't needed any Librium. They show no signs of withdrawal. The crisis has passed, and you can send them out, to treatment. If you start that detox process by putting them on a scheduled dose, well, now you've introduced some uncertainty. And you don't want to send them out with some benzodiazepines, like you say. And, 4 days, 5 days, most people that we detox, it doesn't take that long. 2 or 3 days with the Librium Detox Protocol, and they're ready to go. The biggest problem is, are they going to relapse once they get out? And that's where all those factors we talk about play a role. So I would never advise you guys to write a prescription for a benzodiazepine, send it with a patient to do outpatient detox. So that's an excellent question. Anyone else? All right. Well, thank you.